Miramar FD, Episode 3.
Welcome to Miramar FD Radio, where our primary mission is to protect, serve, and educate our community with pride and professionalism. And here's your host, Jose A. Gregorsh.
We believe leadership is demonstrated through integrity, commitment, loyalty, and humility. Welcome to Miramar FD, Jose A. Gregorsh here, and today it is Tuesday, October 14, 2014. In today's show, we'll be interviewing Dr. Mehta, who is the Medical Director of Stroke and Neurocritical Care for the Memorial Neuroscience Institute. Dr. Mehta, welcome, and thank you for joining us this morning. How are you, sir?
Good. Thanks for having me, Jose.
Oh, absolutely. It's an absolute pleasure. I know it was kind of short notice, and you made time and took away time from other things to be here, but important topic, there's no doubt, what we'll be discussing today, which is essentially a stroke, and we're going to aim to educate folks a little bit on some new advancements. And so we'd like to start off, if it's okay with you, with just asking you some general questions on the topic. First of all, is it true or false that strokes are the fourth leading cause of death in the U.S.?
That's absolutely true. Strokes, besides heart disease, cancer, it is up there in terms of its impact on the overall population and the potential for morbidity as well as mortality after a stroke occurs. And therefore, it's very important to, have the message out to the public in terms of recognizing the signs and symptoms of a stroke, because these days there are a lot of things that we can do in the hospital after patient presentation to potentially reverse the course.
Now, is it true or false, fact or fiction, that stroke cannot be treated?
Yeah, so, it used to be about 15, 20 years ago, before some of these, advances in medicines as well as technologies, that, stroke was, similar to a lot of other, serious life-threatening conditions, a death sentence. Patients presented, we did not necessarily have the appropriate imaging modalities that are available to us today to really identify what was wrong with the patient and, give them the timely therapies, which we have at our disposal now. And so, the current medications that are available, particularly the IV clot-busting medication called IVTPA, which stands for tissue plasminogen activator, as well as some of the advanced devices that we can treat patients with through a catheter-based approach, similar to a patient who's experiencing a heart attack and is taken to the cath lab. We can really do some amazing things after a patient comes to the hospital to a point where they can get back to a meaningful quality of life.
Wow, incredible. Now, is it fact or fiction, again, that up to 80% of strokes are preventable?
Yeah, so that's absolutely true currently. Again, the data, about 2 decades ago, it was not the case. Patients presented, they basically would be severely debilitated and then, require nursing home care lifelong, and that was essentially it. But these days, because of the imaging modalities and the medicines, the devices available, we really advise patients to call 911 as soon as they recognize the signs and symptoms of a stroke, and those being, potentially one-sided weakness in the arm or leg, slurred speech, inability to see on one side of the body or the other. Those are some key triggers to pick up the phone and call 911, because it could be the sign of an impending stroke.
Who's more at risk, women or men?
Yeah, so unfortunately, women are more at risk after having a stroke, as well as just risk for suffering from a stroke, and the reasons are overall not clear. There's been a lot of studies that are ongoing to identify the potential risk factors, especially isolated to women, that men may not have, and see if we can prevent them so that they don't suffer from a stroke in the first place. And once they do experience a stroke, unfortunately, they do a lot worse than men. And that's with regards to some of the causes of a stroke. Women have sometimes abnormal blood vessels, the lining of blood vessels that predispose them to having a tear in the artery, which then lead to a blockage and then a clot going up to the brain, which men are not as predisposed to. And that condition is actually called Fibromuscular Dysplasia, or FMD. And we really try to increase awareness among women, who may be potentially at risk based on family history of a stroke, that, to have that condition, be evaluated for and potentially, be enrolled in some ongoing research studies.
But for men or women, those signs and symptoms would still be,
Yes.
We're still looking for the same three basic
Correct.
that you mentioned earlier.
Yeah.
Now, we talked about IV TPA briefly. Within how many hours from the time of onset can that clot busting medicine begin for a patient who suffered a stroke?
Right. So it used to be, there was a strict 3-hour time window as approved by the FDA. That after a patient presents to the hospital, from time of symptom onset is when the clock really starts ticking. And so once a patient arrives, they may be already an hour out from the onset of their symptoms, or, worst case scenario, let's say 2.5 hours out. And then the ER physician, in conjunction with the neurologist, only has about 30 minutes to really make a quick decision with the imaging, labs, and so forth, and that, if necessary, to give this potentially life-saving medication. More recently, over the past couple of years, studies out of Europe and subsequently in the US have expanded the time window for IV TPA up to 4.5 hours. And that's for a select population subset of patients. And so it's not for all patients who may be experiencing an acute stroke. And that's mainly because, TPA, the effectiveness is time dependent, as well as the potential side effects from TPA. So, in terms of the effectiveness, the goal of TPA is to lyse the clot, is to break up the clot in the blood vessel. However, the farther a patient goes after symptom onset and having a stroke, that area in the brain, the damaged area, the core in the brain, is continuing to expand. And so if a patient presents 3 hours after TPA versus 6 hours after symptom onset, for example, then they may potentially have higher risk for bleeding into the brain. And so the stroke at 6 hours might be more established and bigger than a stroke, say, for example, very early on, at 1 hour after symptom onset. And so the earlier the patient presents and gets the TPA by the clinician, the physician in the ER, the better the likelihood of a good outcome, as well as lower the probability that they will have bleeding anywhere in the body, particularly the brain. And that bleeding risk is about 6% based on, the national trials. And so, we always say, of all the patients that get treated with IV TPA, let's say we treat 100 patients, how many patients will benefit? It's usually about 33% that will benefit in terms of their neurological deficits returning completely back to normal, improving back to normal versus close to normal. And then the remaining either will not have any improvement, but a minority will undergo some, adverse event such as bleeding. And, that usually is rated at about 6%.
You mentioned family history earlier. Is there anything that folks can do to prevent the risk of stroke? Yeah. Are there any lifestyle changes that can
Definitely. So, so very similar to, patients with heart disease, the risk factors for a stroke are, very similar. So that includes having high cholesterol levels, high blood pressure, history of smoking, family history, of a stroke, especially, someone suffering a stroke at a young age, kind of give a tip off that, do they have some kind of clotting disorder that we might need to check for. And atrial fibrillation, meaning a fluttering of the heart that sometimes, especially in older patients, predisposes them to form a clot, which can then go to the brain and cause a stroke.
True or false? Recent advances in interventional stroke treatment can open up a blocked artery more than 90% of the time.
Yeah, very true. So, and now the rates are even approaching close to 100%, where, we had initially a corkscrew-like device back in 2004 that was approved by the FDA called the Mercy Clot Retriever. And that, was demonstrated to be somewhat effective. It received FDA approval because the study showed that it was good at opening up the arteries, but they didn't really, the approval was not based on the fact, how long it took the artery to get opened up by this type of device and what was the effectiveness. Was it 90% versus 40%? And so then we had further advances in our devices. And so in 2007 came a aspiration catheter by a company called Penumbra out west in California. And basically the goal of that was to latch onto the clot and have the negative suction. It's almost like a vacuum, and really suck out the clot, to put it simply. And that was also shown to be effective. But the patients also, in these studies did not have really much better outcomes than the corkscrew device. And so then about 2 years ago came the stent retriever. So that's the short name of it. This type of device is basically a retrievable stent. So a stent goes up into the blocked artery, it ensnares the clot, it expands into the clot, and then you can retrieve the stent. Traditionally, most stents are meant to be deployed, and it's a permanent implant wherever in the body you're treating.
Right.
But with this type of device, the beauty of it is it's attached to soldered to a wire that you can then pull out and block, and so the clot is meant to come out, ensnared within the stent itself. And the studies demonstrated that the rates of vessel opening with this type of innovative device, the third generation, was nearly 95%, even higher in some cases. And so now we're using a combination of the suction catheters by Penumbra as well as the stent retrievers by companies like Covidien and Stryker, and the results are fantastic. For example, just over the past couple of months, I've treated some patients in their 70s, 80s, and most recently a 90-year-old at Memorial West, and we achieved a rate of recanalization in these situations, vessel opening, 100% of the time.
Incredible.
And the 90-year-old that we treated actually walked out of the hospital a few days later.
Amazing.
He came in, inability to move his arm or leg, wasn't able to talk. And the next day after the procedure, he said, "Doc, I'm ready to go dancing." And that was incredible to see.
Oh my goodness.
So, yeah, very
Amazing.
satisfying.
Excellent. That's excellent. Amazing how long we've come
Yeah,
in a relatively short period of time.
definitely.
What is the most effective interventional stroke therapy available on the market today?
Yeah, so the stent retrievers, I would say, are indeed, the most innovative. There are some other therapies in the pipeline. There's a lot of research that's going on into neuroprotective strategies, including cooling of the brain. And so what we can do, similar to a patient who suffered a cardiac arrest,
Right.
and, within the first, especially the 24 hours after a cardiac arrest is the most critical period, similar to the brain, how can we really slow down the metabolic activity in the brain so that it does not demand as much oxygen until the vessel is opened up, so that the neurons don't die, prematurely. And so we're, studying some of these cooling devices to see how we can lower the body temperature, and particularly the temperature in the brain, in the acute setting as soon as patients arrive to the ER, and while we're administering these potentially life-saving therapies. Generally, stroke treatments and stroke field itself has been, I would say, a decade or more behind the cardiac field. So, patient experiencing MI, a heart attack, they can get these treatments, and traditionally they've been getting these types of treatments, very rapidly. They come into the hospital, they aim for a door to balloon time, of a certain number of minutes, and they have to open up the vessel because time is everything. Same thing with the brain.
Right.
Time is brain. And we're now trying to, mirror what the cardiac process is in the hospital, because we are now at the same level, same phase where cardiology has been for years, and we have these innovative technologies available, but we just need to now begin to deliver them as rapidly as possible. So it's a very exciting time, and the main takeaway, that I give patients as well as to the community is recognize the signs and symptoms. The American Stroke Association has done a wonderful job with the FAST campaign, and so that's face asymmetry, arm weakness, slurred speech or speech impairment, and time. So you have sudden onset of any of these symptoms, call 911 and get to the nearest hospital where they can perform these treatments. And, currently, despite our public education and awareness efforts, more than 60% of the time, patients experiencing a stroke, they don't call 911 until an hour after their symptoms have come on. And so that's why, it's important that we, have sessions like this today and ongoing education and awareness so that patients get to the hospital in a timely manner.
Excellent. And we leave you with that thought, Dr. Mehta. Thank you again, sir. It's been very informative. Please never hesitate to dial 911 if you are experiencing what you feel may be a stroke, as Dr. Mehta has gone over some of those details. And we thank you and hope to stay in touch with you again in the future.
Thank you, Jose.
Yes, sir.
Thank you for listening. This has been an official recording of the Miramar Fire Rescue Department with your host, Jose A. Gregorsh. Miramar FD is on Facebook and Twitter. Search for keyword Miramar FD in order to interact with us. Also, subscribe to our podcast in order to receive future valuable information.